Ladies and gentlemen, please take your seats. The program is about to begin. Ladies and gentlemen, please welcome to the stage Foreign Policy Executive Vice President Allison Carlson.
Hello, good morning, everyone. Thank you so much for joining us today. We know this is a tough time of year. We're getting close to the holidays, but we really appreciate you taking the time to join us today for an incredibly important topic, and addressing the future of cancer care. At Foreign Policy, we have the opportunity to bring together leading experts from around the world that are working on a range of issues that require multi-stakeholder collaboration. And with cancer being the second leading cause of deaths worldwide, with low and middle income countries bearing the brunt of the burden, and without question, cancer affecting in one way or another almost everyone in this room and all of our lives, I can't think of another issue of more import, and that requires multi-stakeholder, cross-sectoral, and international cooperation to really ensure progress. Today, in partnership with Burjeel Holdings and on the 10th anniversary of Burjeel's Oncology Conference, we have the honor of bringing together medical practitioners, scientists, policymakers, and those who are really working on the front lines of these issues to not only talk about the challenges, but to really focus on the promise. What are the solutions? What's being done in terms of technology, the advancements that are having real impact now, but also what needs to be done to ensure faster, greater progress going forward. I again thank you all for taking the time. We have an incredible group today who will be focusing on these issues, but also understand that in the room, we have a tremendous amount of expertise and experience, and so we want this to be interactive. We want you to all engage with each other afterward as well. Thank you for being here. So without further delay, let's get started.
Please welcome to the stage Assistant Director for Cancer Moonshot Engagement and Policy at the White House Office of Science and Technology Policy, Dr. Catherine Young.
Thank you for joining us.
Thank you so much.
I am incredibly honored to kick off today's event in conversation with you. You are leading the Cancer Moonshot and working with a team at the White House and as part of the administration to really drive forward President Biden and Dr. Jill Biden's initiative, ambition to really have a tremendous near-term impact on reducing cancer deaths by 50% in the next 25 years. Those are ambitious goals and honorable. How do you make it happen? What are, for those who aren't aware, what are some of the core principles and components of the program that will enable and are absolutely essential to making progress happen?
Yeah, well, first of all, Allison, thank you so much for this opportunity to be here with all of you. Yes, you're absolutely right. The goals are ambitious and bold, but we do believe are very achievable. And as you mentioned, the first goal is to reduce the cancer death rate here in the United States by 50% over the next 25 years. But we actually have a second goal as well. So as a scientist, I love numbers and stats, and we always drive towards those numbers and metrics. But the President and First Lady always impress upon us that those numbers represent human beings. They represent our loved ones, our parents, our children. And so because of that, the second goal is to improve the experience of those living with and surviving cancer. And we have made and delivered great progress on both of those components. And as you mentioned earlier in your introduction, a big part of that is bringing together the community to really drive forward and drive progress forward together. Because we know that not one organization, not one government, not one country is going to be able to really comprehensively tackle cancer being such the complex disease it is. But together, we can make a difference. And what we are seeing with the Cancer Moonshot and with the inspiration of the President and First Lady is a movement driving progress forward against cancer in all aspects.
And so when you're thinking about this challenge and thinking about the timeline and understanding there are resource constraints and a number of challenges, how do you prioritize? And in the action agenda, what is first and foremost in your mind that needs to happen now?
Yeah, absolutely. When we think about cancer as a whole, it is overwhelming because there are so many aspects to that cancer patient journey, from diagnosis all the way through survivorship, and then all the other external components: financial toxicity, childcare, how do we get to and from appointments. So it is a very complex kind of landscape to navigate in terms of how do we really approach solution making towards this. We have taken the approach, and the president, when he reignited the Cancer Moonshot along with the First Lady last year, convened for the first time a cancer cabinet. This brings together over 20 different departments and federal agencies together to really sit at the table and identify solutions moving forward. The Cancer Cabinet has put forward 5 specific pillars that we deliver progress on. So, for example, the first one is closing the screening gap. We know that during COVID, we lost over 1 million cancer screenings. It is imperative that we close that gap and catch up, because we know that the best outcomes occur when we catch cancer early. The second pillar is around environmental and toxic exposures. How do we ensure that we are cleaning up our toxic sites in the United States and tackling things like forever chemicals and pollutants? The third is preventing cancer before it even starts. We already have so many tools in our arsenal to prevent cancer. We need to make sure that these tools are made accessible to everyone in the United States and really around the world. This includes things like the HPV vaccine, which actually prevents certain types of cancer. Smoking cessation. We know that smoking is the single most biggest driver of cancer here in the United States. Nutrition, lifestyle, all these things matter, and those are the things that we're focusing on. The fourth is really driving innovation, so infusing that sense of urgency into new treatments, new therapies, new tools and resources, but making sure that what we produce and create actually reach the communities all across the United States, and that it doesn't just get held in these pockets around the country, but that it touches everybody and everybody has access to that. And then the fifth pillar that we focus on is centering the patient and the caregivers. That means making sure that they have the support and the tools and the resources that they need in order to be able to traverse this very complex journey when you get diagnosed with cancer in the best possible way. So being able to define that work and deliver progress around those 5 pillars really helps us focus, but also provides a mandate for us and the Cancer Cabinet and the federal government to really drive progress towards that.
You raised so many important points, and very notable about the cabinet. I think oftentimes with issues that are so broad, there's siloing of effort.
Yes.
And with such ambition, there really needs to be greater cooperation across agencies, streamlining of activity, recognition of what efficiencies can be had so that that effort isn't fragmented.
Absolutely.
And so I think that cabinet speaks to that, and that
Absolutely.
ability to understand what are the complementary roles that everyone has to play.
Absolutely. And I think to that point, when you think about a cancer cabinet, you think about the typical agencies that are health related, CDC, NIH, NCI, HHS, all the acronyms. But we bring together the kind of non-typical agencies that you would think about as well. So NASA is part of our cancer cabinet, Department of Energy, Department of Commerce, Department of Labor. All of these agencies are bringing to the table very specific skills, resources, and activities and initiatives that are all touching the cancer journey in very different ways. So in a way, we are tackling this in as many different angles as we possibly can, and bringing these agencies together, convened by the President and First Lady, is the exact way to break those silos down, for sure.
And I'd like to pick up on what you said about early screening and how important that is. And the statistics of how many did not receive screening during the pandemic. And when we think about that and we think about access, how can we ensure, and how are you, the administration, working with other partners to ensure access, and not only access, but to ensure that access is equitable?
It's such an important part, and I'm so glad you raised that. Screening and prevention, early detection, these are areas that we are very focused on because, again, we know that the greatest outcomes occur when we catch cancer early. And so how do we ensure that these resources and screenings are made accessible throughout our country? And we've done a lot to try and make sure that this actually happens. The CDC has actually committed $1 billion towards ensuring cancer screenings across the country and has already released hundreds of millions of dollars to every single state here in the United States to ensure that accessibility of cancer screenings. The other thing that we think about is how do we make sure that when patients get the screening, that they also get the care that they need beyond that. And so, for example, the Health Resources and Services Administration, or HRSA, has really worked to create partnerships between federally qualified health centers, or FCHQs, and NCI-designated cancer centers, so that when patients receive their screenings, perhaps get a diagnosis of cancer, there is a pipeline already established that those patients can get the care and the treatment that they need. So we think about it very holistically, and not only that access part, but also how do we ensure that that entire pipeline is free-flowing and that patients can get from one side to that treatment and care side as quickly and as efficiently as possible.
And when you're talking about care, it brings to mind access as well to advanced, high-quality care. And there's so much happening, which we'll talk about today in a little while in greater depth with technological advancements, and in particular AI,
Right.
and the potential that that holds for cancer early detection, screening. But obviously, it's also very much under development. There is a lot to be done, a lot to be learned, a lot to be refined. And so when you think about the activity of the moonshot and also other activity across the administration as it relates to artificial intelligence, how are those two issues being bridged?
Yeah.
And what is the work that you're doing to ensure that the interventions are technologically advanced, but then also in a way that is ensuring access and equity, as you just described?
Yeah, absolutely. We're sitting at the precipice of this new world with the advancement and the acceleration of technology, but specifically AI. And the way that we view it is that, yes, and I know you will speak more about this later in the program, but there will be so many benefits coming out of AI when it comes to cancer treatment, cancer diagnosis. The question is, how do we ensure that the AI technology is deployed in a way that doesn't perpetuate biases that already exist in the healthcare system, and also doesn't perpetuate the inequalities that exist in communities already? And the administration has taken many steps already to ensure that we are thinking about the use and the design and the deployment of AI in the most safest, responsible way possible. It is really our duty to make sure that we get this right. And so, for example, they released a landmark blueprint for an AI Bill of Rights, which lays out 5 principles to guide the use and deployment and design of AI. They've also been able to get voluntary commitments from major AI companies to make sure that AI is developed in a safe and responsible way. And the last thing I'll just mention on this is that just recently, the administration issued an executive order to ensure that the federal agency has the power to advance AI in the most responsible and safe manner, and self-respecting way as well. So we very much, as an administration, are thinking very critically and intentionally about how do we deploy AI in the best way possible while balancing the excitement for what is to come, because I think really our imagination is our limitation here, right? We actually don't know what's coming because we cannot probably perceive it right now. But we do know it will have a major impact, not only in cancer, but healthcare in general, I believe.
Absolutely, and eager to dig into that in more detail with some scientists and others who are working very much at the heart of the development of AI technologies in just a few minutes. And we have only a few minutes left for our conversation, but I'd really like to ask, and as we're foreign policy, the moonshot is ambitious and very importantly directed at these goals in the US, but also know that it extends internationally. And so I'm wondering if you could speak about that a little bit. How can the activity, the investments, the lessons learned as part of the moonshot be applied internationally?
Yeah, that's a great question. The mission of the Cancer Moonshot is so important, but we definitely believe that this mission needs to go beyond our own borders as well. And so working with global partners is an important aspect of the Cancer Moonshot. Most people, when they think of the Cancer Moonshot, do think of it as a domestic initiative, and rightfully so. Much of our efforts go here to the United States. But actually, when it was first ignited back in 2016, there was already an international component, but we are now expanding upon that. Actually, our international work really kicked off in earnest a year ago with the African Leaders Summit, where President Biden brought together leaders from Africa here in Washington, D.C., and as part of that, the First Lady announced over $300 million in both federal and private sector commitments to Africa to increase healthcare resiliency, to train the workforce, to ensure access to treatments and therapies, which are so needed. And so that was the catalyst for our international work, which is only going to grow. President Biden often says that when he meets with leaders across the world, the one thing that is in common that they want to talk to him about is cancer. And because of that, we have had a number of cancer cooperation commitments come out, such as the Republic of Korea and India. We work with the UK and the EU, because again, to the point I made earlier, and you did too, we cannot do this alone. And we will only accelerate our progress forward by working with our international partners as well.
Very well put. And you raise an important question as well that we'll dig into more throughout the course of this morning, which is about funding and how to mobilize the resources necessary, the financial resources, but also the other resources that are necessary to have the impact here in the US, but also abroad as well. So thank you for your work, and thank you for being with us this morning.
Thank you, Allison, so much. Appreciate it. Thank you.
Now, please welcome to the stage co-chair of the Congressional Cancer Caucus, Congressman Mike Kelly, for a conversation with FP's Allison Carlson on policies for a cancer-free future.
Congressman, welcome. Good morning. Good morning.
Thank you. It's good to be with you.
Thank you for joining us.
Thanks. I had talked to somebody. I want to introduce somebody that came with me. Hannah Adams is in the back of the room. I'm a Hyundai automobile dealer. Listen, I never wanted to be in Congress. I like being in the business, like the private sector better. Hyundai has something called Hope on Wheels, which we're going to talk about a little bit. But Hannah was one of our youth ambassadors, and the key to it is having young people talking to other young people who are going through it, and they're cancer survivors. So when you see her, you'll understand why she's been so popular with us, and we're looking forward to being Miss Alabama. So I know we're going to start a conversation. Listen, good morning, everybody. Good morning. I don't know. So I was at Mass at 7:30 and trying to figure out what the day was going to look like, and I felt good coming out of church, which is the idea, right? You go in and you come out, you're supposed to take everything out that you experienced in church. So it's really good to be with you, and you're all in the same mission right now, and that is this terrible, terrible disease that strikes so many of us. So
yes,
I'm sorry.
Absolutely,
listen,
and welcome. Thank you for
Hannah,
joining us.
can she come up so everybody, just to sit down with me?
Absolutely, of course. I don't know if we have a microphone.
She's not my daughter. But
Hannah, welcome. Thank you for joining us. It's a pleasure to meet you. Thank you for joining
So,
us
all right,
today.
you good?
Yes, sir.
Okay, good deal. Okay.
Please have a seat. And thank you again. We know schedules are hectic. You have votes later today,
yeah.
and so appreciate you carving a little bit of time out for us and also for joining us. I think you said it very well. These, communication matters. Bringing in the voices of young people matters.
Yeah.
I'd like to kick off our conversation to understand a little bit more about the priorities of the caucus and the Congressional Cancer Caucus as you're co-chairing that as well. We just heard from Dr. Young about the importance of all of government and the need to really mobilize efforts and resources to address this really pressing issue that touches all of us. And so, as your co-chair, what are your priorities and a view from Congress?
Do you know what? I've had a unique experience in that. I'm now in the political world, but I was also in the private sector. And I think the combination of the two, with the STAR Act and the HOPE Act, we went through, and then, the legislative process is always very difficult, and it's hard to get people on board to do something like that. So we're always looking to do things like that, and the idea is, at the end of the day, where are we generating enough funding to go through what we have to go through to get to an answer? My role was easy for me because we started in 1998 with Hope on Wheels and Hyundai, the idea that the private sector could do something when it came to a really serious problem. And so we're in our 25th anniversary. We've raised about $225 million that has gone into research. It's much easier to raise money in the private sector than it is politically, because the process gets so drawn out and so long, and it gets thrown in with everything else. We really believe that it's a retail effort. It's a retail effort to handle something that affects every single one of us in one way or another. We've either had that experience ourselves, or it's in our family, or it's in a friend, it's somewhere in our community, and we know what it's like. And it really, until it hits you, it doesn't hit you when you realize what you're going through. So I wanted Hannah to come today, because when I met her, she was 12 years old. She was a cancer survivor. And with Hope on Wheels, we have youth ambassadors. Now, this all plays into what we're talking about, right? Because you've got to get people to look at it and say, okay, fine, you know what? This affects me as much as it affects them. So if I were to go in to a ward where children are fighting cancer, I look like somebody's grandfather. And I am. I have 10 grandchildren. But Hyundai Hope on Wheels was, why don't we get people the same age as with children and what they're going through? Because when you look up from that bed and you see somebody that you recognize and you could communicate with, it's a lot different than an adult walking in the room. So you can imagine, as a 12-year-old girl when I first met her, and then going to cancer wards around the country and seeing the effect that it has, and you see it in their face, you see it in their eyes, and you see them look up, from their bed, and they have so many things hooked up to them, and it's like, oh my God, we've got to be able to do something. But the key is having people that can communicate right now. That's the whole thing, what I go through, honestly. Getting people in Congress to walk out of thinking of themselves as a political person, but thinking themselves as a private sector person, and the issue that's in front of us, then why can't we all just unite around that and forget about the other aspects of what it is that we find things that we can't get along with, which to me is absolutely insane. But this situation and what you're all doing, I got to think when you get up in the morning, you get up and you get out of bed for a really great reason. And when you can look in the face of these people that are going through this, not just the children, but parents, moms and dads, grandmas and grandpas, friends and neighbors, and when they can see that light, that hope, and think, you know what, there's other people that are willing to jump in the fray and try to defeat it. So I have truly been blessed in my life, as all of us have, at one point or another. But this issue, more than anything else, unites us rather than divides us.
You're absolutely right. And as we were discussing earlier, I think all of us in this room and all of those who will watch the recording of this are somehow impacted, and lives of friends, family members affected by cancer. And it is a uniting issue that we all need to collaborate to work together on. And in addition to being the co-chair of the Congressional Cancer Caucus, you're the founder and co-chair of the Childhood Cancer Caucus as well. And I'm curious how that connects to your work with Hannah, and also what is being prioritized specifically as it relates to childhood cancer.
Yeah, well, I think what we find, and again, having gone through the experience of raising 4 children and now watching 10 other our grandchildren grow, there's just a unique bond between us when it comes to us and our children, and even our nieces, nephews, and then other people. I think what we've tried to do is to bring it down to the human experience as opposed to a political experience. Because too often we don't fight on policy, we fight on politics, and which is not a good thing to do. And it's hard, it's really hard, and sometimes it reduces you to tears because you start to look at what's happening, and as much as you want to remain strong and think, sometimes the emotions take over, and you start to get to the point you say, I don't get it. And I don't know why I can't get you to get it. But it's that experience that happens. So again, you got to find a way to connect people. And I always thought that the greatest people in the world that I've been around is when I go to like the Children's Hospital in Pittsburgh and talk to the doctors who get so little praise. They just come to work every day to do one thing, and that is to make sure that somebody's child gets healthy again, or we prevent the occasion where you hear the thing, your child has cancer, and we're trying to get through all that. But, the legislative part of it is more difficult than it should be. And so you got to reduce it down to the human aspect of it, as who it is that we're talking about. So again, I'm repetitive on this, but I think so when Hannah was going around and watching her communicate with other children, to see it's in their faces that you see it. It's in their faces, and it's in the faces of parents and grandparents when they see, what somebody else is feeling the same thing I'm feeling, and is saying, what, who is it that's going to come up and do this? And the answer is, go find a mirror and look into that mirror. And that's the person that's going to make a difference. For me, it's been an incredible experience. But to be around, I've watched her grow from a 12-year-old now to competing for Miss Alabama. And I'm thinking, wow, what a great ambassador we have. So, but again, it comes down to the funding. And I think the private sector also, it's easier for me to raise money in the private sector than it is on the floor of Congress. And we're today going to debate, and we're going to try to pass the National Defense Authorization Act. And it's difficult because the title doesn't really tell you what's in the bill. And we find things that we argue about. But in this situation, there should be no argument at any level from any person. And once they experience that, or have somebody that's experienced that they're close to, that's the easiest thing to do.
Absolutely. And you raised such an important point on funding, and also the need for the public and private sector to really work together to mobilize funding in order to allocate it to what's needed and the programs that are having the greatest near-term impact, as well as the longer-term research and development. We only have a few more minutes, but Hannah, I would like to hear from you as well. I don't know if we have another microphone at all.
Here, you know what? Here. You're just talking by time. Here, I know what I'm. Here you go.
There we go.
But just as we close out, and really want to shine a light as well on you and your experience, thank you very much for joining us today and hopping on stage, unprepared, but we are talking about the human face and the human experience, and wondering if you could share for a few moments about your experience and the importance of this partnership and the impact that you're seeing it have.
Yes, so my name is Hannah Adams. I'm from Birmingham, Alabama. I'm currently a junior at the University of Alabama studying political science and public relations. And my connection with childhood cancer started about 14 years ago. I was getting ready to go to ballet class, and my mom noticed a slight bulge in the side of my stomach. Instantly, her mom sense went off, and I went to my pediatrician the next day, who knew that something was wrong. After some blood work, some scans, I was diagnosed with stage 3 nephroblastoma, which meant that a softball-sized tumor was enveloping my left kidney. And with the genetic disposition, I was one of 9 kids in the world diagnosed in 2009. So it was really rare, really aggressive, and my days of swimming with my friends and playing dolls with my sister turned into hospital visits and having part of my childhood taken away, going through things that no kid should ever have to go through, but also no family, no parents, no siblings should ever have to go through. But after chemotherapy, radiation treatment, and surgery, I was finally declared cancer-free 14 years ago. I celebrated it on Thanksgiving this year, so extra thankful for that. Thank you. But since that experience, since that experience, that's really what has motivated me to want to help other children who are battling cancer and give them hope and say, if I beat cancer, you can do it too. And so for the past 8 years, I've known Congressman Kelly, and we formed such a great friendship and mentorship, and having people like him on Capitol Hill who are champions for childhood cancer has been so impactful. And just a couple days ago, I was walking the halls of Congress with about 4 other childhood cancer survivors, other kids who had a connection to childhood cancer. And I feel like those are the most effective advocates, is putting a face, putting a name to childhood cancer. And when those kids walk into those offices, you can't turn them down. And I think that's our strategy. That's what we're doing, and really looking at how can we continue to develop better treatments for these kids that are going to be less toxic on their bodies so they can go on to live happy and healthy lives. And so I think that we have so much more that we can continue to do with collaboration, with things like this where everyone's coming together, and really remembering the kids and they're the future of our country.
Very well put. Thank you both for joining us today and for the work that you're doing. We really appreciate it. It's such a pleasure to meet you. Thank you, Congressman. Thank you, Hannah. Appreciate it.
We're going to go vote. So.
Thank you. Yes.
Next, please welcome to the stage radiation oncologist and AI researcher at the Dana-Farber Cancer Institute, Dr. Danielle Bitterman, the World Bank Group's alternate executive director for the United States, Felice Gerardo, Chief Digital Innovation Officer of the Mayo Clinic's Mayo Collaborative Services, Dr. Jason Hipp, and Chief Medical Officer at Aster Insights, Dr. Anshu Jain, for a conversation on the next generation of cancer care.
Thank you so much for joining us. We have a packed panel and stage and a tremendous amount of expertise on stage right now, and a real opportunity to dive in to the science and dive into the technology and really level set about where we're at, what's real, what needs more investment, what needs refining, and the potential impact that it can have. And I'm really excited to dive into advanced care and specifically AI. It's something that I know our audience is, really trying to grapple with and understand not only, what is the potential, but where are we at? What is reality? And also what needs to be prioritized to ensure that there are safeguards in place and to direct the development of technology to the extent possible to really, harness those opportunities. And so I know in various ways you're all working at the intersection of these issues, both here in the US and internationally. And so, Danielle, I'd like to start with you from your research and the work that you're doing. Can you level set with us about the state of the technology as it relates to AI and cancer care, and what you're working on that is incredibly promising?
Sure. Yeah. Thanks for the question. So I do think we are truly at an inflection point with artificial intelligence in general, and specifically in medicine. We've seen in the past year, especially with the large language models, which a lot of people are familiar with ChatGPT. These models are able to do really incredible things, but where we have not really made a huge leap yet is figuring out how to safely evaluate these types of new technologies for healthcare applications. We need to keep the bar at the same level that we have for pharmaceuticals. This is a completely new paradigm and a re-envisioning of how we're going to deliver care to patients. And we don't know all the subtleties about how that is going to influence how doctors make their decisions. And so that's something we have to really keep an eye on. So, we're at a really exciting point. There's a tremendous potential to take this moment, make sure that we have regulations and appropriate evaluations so that we effectively move AI into clinic in a way that helps patients and doctors. And so some of the research that my group at Mass General Brigham is working on is focused on how do we develop AI, and specifically I do work in natural language processing. So how do we develop large language models that can effectively mine the electronic health records for information that we don't readily have access to for research and for patient care. So things like side effects of treatment, which contributes to patients' symptom burden, where there's a lot of need for more research understanding, and social determinants of health, which we know have a huge impact on the disparities crisis in our country, but we don't have enough data to understand what are the specific factors that we need to target. And then along the lines of what I had previously said, we need to really understand how doctors interact with automated recommendations. And so we are doing work both for radiotherapy planning and for clinical decisions as recommended by language models to understand how do we make sure that doctors stay vigilant when being provided with automated recommendations so that we get all the benefits of AI, but make sure that we are still able to take advantage of the nuance that really only expert doctors are able to provide for those hardest parts of treatment decision making.
Okay, thank you. It's incredible to really dive into the specific applications and the work that you're doing, but also be clear-eyed about some of the challenges that still exist and need to be grappled with and addressed. Jason, I'd like to bring you in and hear from you in terms of what are some of the advanced technologies and applications that you're seeing with AI or other technologies as it relates to diagnostics, early detection, and how is that translating into therapies?
Great. Hi everyone, my name is Jason Hipp. I'm a pathologist by training, so my expertise is in diagnosing cancer. And at the Mayo Clinic, we're trying to develop AI algorithms that can help pathologists diagnose cancer faster, better, more efficient, and more accurate. And the goal of what we're trying to do is develop AI algorithms so we can give the quality of care that you receive at Mayo Clinic globally. So where patients throughout the world can be able to upload images. So their tissue, what we do is we take images of patients' biopsies and tissue samples, upload it, and use these AI algorithms to get them the highest quality of care. Right now with pathology, a lot of pathology is practiced in the community. Small hospitals, you have one pathologist that has to cover all the disciplines. At Mayo Clinic, we've got 20 subspecialty divisions, people just seeing specialty, and we want to give that care globally. So we want to improve the quality of care, but also from an innovation perspective, we want to do things that pathologists can't do, but would help patients the best and help doctors. So what we want to do is to develop new diagnostics that could predict what therapy should a patient get. Rather than just giving systemic therapies that has terrible side effects, we want to use AI to see patterns within the tissue, within the image that humans can't see. Use that information and say, actually, you should have an IO therapy, you should have chemotherapy, and also, by the way, here's your survival. We should think about this we should augment your therapy. Lastly, my background, I come from the pharmaceutical industry, and when we think about drug development and the importance of diagnostics, this is where I take my pathology hat off and say, what do we do when we integrate multimodal data? You hear a lot of that with ChatGPT, Google's LLM models, where they're taking images, voices, and other types of data sets to integrate it. We want to do that for our patient care, where we can take a radiology image, a pathology image, the genomic sequencing. And what happens when you add 1 + 1 but start getting 3 and get enhanced? What we don't have. So we want to elevate the standard of care for new therapies, new drugs, by trying to understand what is going on in the tissues with AI algorithms that can see every little pixel, every little quality within an image. So that's very, very exciting. It's new, it's innovative, but we need to have the policy because there's a lot of equity issues that need to be addressed. So we need to couple policy issues with the early advancements and have them jointly moving forward rather than rushing with the science and trying to figure out from a policy perspective what needs to be done.
Thank you for that. And I do want to dig into that bridging of the technology and policy space and how to better align upstream so that there's greater cohesion there. We'll come back to that in a second. But Anshu, I'd like to turn to you and hear, in your work at Aster Insights, what are you seeing in terms of the trends, in terms of advanced technology development, what we've already just heard, and how can we ensure that we're not getting wrapped up in we being broader society wrapped up in hype, but really methodically translating technologies into methodical evaluation and deployment. What are you seeing in the work that you're doing and what's front of mind for you?
Well, first of all, thank you for having me on this panel and being up here with several of our esteemed colleagues here. The conversation I'd like to shift a little bit of attention to around Aster in particular is the focus on patients. I'm a practicing oncologist, and by and large, I see patients all the time who are really interested in being able to participate in how to improve cancer care in this country. And oftentimes, there aren't a lot of vehicles for them to do so. And at Aster, what we do is we work with nearly 20 of the leading cancer centers across the country, administering what we call a total cancer care. It's the largest observational oncology study in the world. And we've consented to this study nearly 400,000 patients. And what that allows patients to do is share their data of their cancer treatment journey for the purposes of research and to improve the cancer care experience for future patients. What I also see across the country is that we have some of the world's leading researchers in cancer at some of the top institutions in the country. Oftentimes, these researchers are limited to the data that they can work with. They're limited to institutional data. What we want to do and what we have been doing is providing an opportunity to collect these patients' data from across the country at these leading cancer centers and take that data and curate it. We take the patient care data for cancer patients, we develop data sets, and then we share that data back to the cancer center so they can learn from each other's experiences. And we also are able to take that data and work with our life sciences partners to accelerate new discoveries in oncology. And to your point, when we talk about what are we seeing in terms of new technologies and new therapies, one of the examples I always like to quote is that our data was actually instrumental in driving the expansion of immunotherapy, where it was originally used in only 2 indications. We were able to use our data to show that it had activity in several additional tumor types and an expansion to over 15 indications in 15 different types of cancers. And so the ability to learn from patients and patients who want to participate in the improvement of cancer care, I think is paramount to the experience and how we can actually drive discoveries in cancer. To the point around AI, I think that the point I would make is it's critically important to have data that represents patients across the spectrum. We need to have data that represents patients both with geographic diversity, racial diversity, socioeconomic diversity, to be able to understand how do patterns of care differ across different patient populations. And that's what we seek to do, and that's what we're doing today at Aster Insights, is developing that type of data so that as we train AI algorithms that look at issues around access to care or understanding the role of social determinants of health in cancer care, we're utilizing a data set that represents the patient population as a whole and is not just focused on a more narrow population.
Thank you for that. And you raise a number of important points, one of which I'd like to pick up on now about the importance of cancer care and understanding context and different geographies. And Felice, I'd like to turn to you and hear a little bit more about what brought you to this issue, and also now in your role at the World Bank. You know, a lot of what we are talking about is innovation and activity that is in the US, but also we've underscored the importance of international collaboration and understanding how can these advancements be translated, and also how can access be increased in other countries around the world that don't have as developed infrastructure systems, healthcare systems, et cetera. So I'm wondering, you know, in your experience and also as you're hearing the conversation this morning, what is front of mind for you?
Thank you, Allison, and thank you to Foreign Policy for convening us and organizing today's conference and facilitating this conversation. I just want to take it for 1 second to the human level. How many of you here have had cancer or a cancer survivor or currently a cancer patient? How many here have been a caregiver or a family member for someone in your immediate family directly impacted by cancer? I think pretty much all the hands are going to go up. And so this is really personal, I think, to a lot of us. And I can't agree more with the congressman as he was talking about it. This should be something that unites us all. And what drove me to take action in this space was almost about 10 years ago, my mother was diagnosed with pancreatic cancer, which, as for those of you who know a little bit about pancreatic cancer, is basically a death sentence. And she was a young mom who had become a young grandma to my kids, incredibly active, no prior history. And it shook us at our core that this disease could basically give her a death sentence, and that everywhere we went, the options were incredibly limited. I had worked previously in the Obama White House, but at this point I was outside of government. Similar to the congressman, I was in the private sector, working in technology, but nothing having to do with cancer. And at an event where I was invited back to DC, I had a chance to speak with then Vice President Biden about his experience with his son, Beau. And it was literally months after Beau had passed away from brain cancer. And when I shared with him what we were going through, being this incredibly empathetic person that he is, he pulled my wife and I aside, brought his wife, Dr. Biden, in, sat us down, asked how we were doing, asked how my mom was doing, asked if he could call her to lift up her spirits. She missed the phone call, but she got the voicemail, and she'd go back to it again and again. And then he asked if there was anything he could do. And at that point, he had access to the medical expertise and cutting-edge technology and treatments that only really him and the president probably had access to. And he facilitated introductions and connections to those doctors. You do that for my family, I'm indebted for the rest of your life. That's just the way I am. Unfortunately, it was just too late. It was too late, and the cancer had already taken hold. After what was brutal surgeries and therapies that would only be called by any other name, torture and poison. That was the best that we had. And when he said he was going to dedicate himself to this crazy idea to try and end cancer as we know it, and said that if we could take a whole government approach, really a whole society approach, to do something as ambitious as put a man on the moon and almost touch the face of God, then why couldn't we do that to try and cure this disease and other diseases? And I called him up right afterwards. I said, I have no idea how I can help. That's not my background, that's not my expertise, but I'm all in. And so I was able, very fortunately, to get involved in the first cancer moonshot from the outside of government, and then later on when he left the office and started the Biden Foundation and launched the Biden Cancer Initiative, serve as an advisor. But that's kind of where I come from it, and where, you know, what my life experience that drove me to take action in this space. Since then, I now serve as the U.S. government's representative on the board of the World Bank, and I have been able to better appreciate the incredible access to technology and cutting-edge treatments that we have in this country. And the importance of us trying to address and bridge the gaps, especially in lower middle income countries around the world. And what I've been impressed to learn about is how the World Bank is really embedding access to care and a digital in-health first strategy in its health programs. And I think you're going to speak to one of my colleagues a little bit later just about that, and I'll leave it to him to kind of address that. But I think when it comes to the technology, and specifically AI and other innovations, tying it back to the cancer moonshot and the global focus that it's had since the very beginning, it's about also leveraging tech that otherwise we wouldn't probably have used in this space to be able to detect early detection, prevention, and also to lower the cost of care. And then when it comes to other parts of the world, I think one last thing I would say is, and Catherine, my colleague, shared a little bit about it, but at the US-Africa Summit, there were a series of announcements that we made, but I think one of them that was probably incredibly relevant to this discussion today was a partnership and an example with AWS, where using their secure cloud computing platforms in Africa, they are using their networks to be able to help African researchers and doctors be able to develop native solutions and also organize their data in a way that can be used for clinical research there and abroad.
Thank you for that, for the context and for sharing your background and your story, and also how that translates into the work that you're doing today. And I think it really underscores the issues related, of course, to equity and access, and how can we bridge that gap between all of these technological advances and access to care to ensure those who may not be in urban centers, who may not have access to the resources, actually get the treatment that they need when they need it. And so I'd like to turn a little bit to those issues of equity and how you all in the work that you're doing are seeing the challenges, but also concrete ways that you see it being addressed and potential solutions to address those equity issues and at that intersection of technology. Danielle?
Yeah, so I think AI in general does have incredible power to kind of democratize cancer care, because we don't want the best care to only be available to presidents. It should be available to everyone. Sure. And where AI has this power is that if we can train AI to emulate the most specialized physicians, especially for rare cancers and childhood cancers, where so people may not live anywhere near a doctor who has specialty in that area, and AI may be able to emulate those most specialized physicians so that that care can then be democratized and spread throughout the country and throughout the world. Now, there are major barriers. The biggest barrier is, how do we train models that are representative of our population? AI models are only as good as their data, and they learn the biases in our data. And the research that we're doing in our lab at Mass General Brigham, we really want to make sure that we are balancing AI advances with ensuring equity, and that our advances are reaching the people who need it most. Because otherwise, you're just going to see those inequities further widen. So we've seen that with kind of the closed source large language models, they change their predictions if you just add in gender and race terms, when there's no other reason that they should change their predictions about a patient's social determinants of health or clinical status. That's something we want to understand and then have the ability to address those issues. The big, what is so hard, and where I think regulation and funding and partnering with colleagues at the World Bank and Felice, is trying to figure out how do we collect data on people who may not have access to broadband internet, don't live in countries where they have electronic health records. We need digital data to train our models, and we need more funding and effort now to start collecting data that's representative. That is the biggest barrier, I believe.
It's an incredibly important point. And Jason, I'd like to turn to you on the issue of data and of bias. And you're absolutely right. the need to collect more disaggregated data to really understand what are the realities in different contexts, in different geographies around the world, and then how can that also be addressed with issues of privacy and other regulations around data sharing and protocols. You know, what are you thinking about in your work as you're really needing to access greater data pools and resources, but also understanding those tensions that exist as well in terms of privacy, particularly in healthcare?
Thank you. When we think of equity in pathology, I think it's really important to understand what the power of the technology can do right now. AI algorithms can see things in what a pathologist would look under a microscope and see things that humans can't see. And what some people have started to show, early studies, is that these algorithms are so powerful where pathologists have been looking at images for over 100 years, but now AI algorithms are trained to diagnose cancer. However, if the AI algorithm was trained on Caucasian patients, it performs good on Caucasian patients.
Right.
If you test it on African American patients, it has a decreased level of performance because not enough data is being trained by the algorithm. So fundamentally, when an algorithm is developed, it's only as good as the data you have. Right now, in a lot of the world, when it comes to pathology data, rich, affluent, Caucasian populations are able to get their data digitized, or institutions are digitizing these data. We have to make sure that we are being proactive globally and within our United States to get diverse data sets so that these algorithms can be fair, they can give high quality of care to all patients. So it's very important when we see these great studies of AI. One of our president of platform at Mayo Clinic has a great analogy that I like to use, is that we should have a recipe guide. We need to know what goes into that algorithm. What patients was it trained on? What are the demographics? Sure, it might not have an immediate impact, but when you think of global, and Mayo Clinic wants to help patients globally, we have to think about this every geographic market, every population, any patient that comes to Mayo Clinic, so they get the highest quality of care. So it's really, really important that we get data sets digitized from an equity perspective and keep that lens in there to create fairness in the AI, so that a couple years from now, when all these algorithms that people are researching go to the clinic, we don't hit this policy now. So that goes back to what I was saying earlier. We need to have that policy influencing the R&D and the research of AI to couple what we're doing here to make sure to highlight these equity gaps and concerns so we can mitigate that now and not do it 3 years later when we're in the clinic and people are getting unfair treatment. So very, very important about getting our data digitized from everybody in the world.
And I think that point is so important as well, so that there's also more accurate assessment and evaluation of those interventions and understand what is working for whom, how can it be refined, and have that be more accurate to then allocate the resources appropriately and where they're needed most. And Andrea, I'd like to bring you in on that point and understanding, too, from your perspective, when we're talking about resource allocation and value-based care, how can we all think about that differently, and how can some of these interventions be prioritized, and how can data be utilized to ensure that the interventions that are being invested in now are those with the greatest near-term impact?
Thank you. We know that cancer treatments work. We know that it saves lives. And we also know that when cancer goes untreated, it can be a major driver of cost in the healthcare system. And so when we speak about equity, we want to make sure that all patients have access to care. And I like to simplify things when I speak with my patients. And so when I think about equity in particular, I like to think about a tall person and a short person. And there's a table that has the treatments on them. Can they reach the treatment? That's what I think about. How do we actually help somebody who may be shorter and lift them to have the same ability to reach the treatment that the tall person does? And so that's kind of the first step in the delivery of cancer care, as I see it, is to make sure that we all have access to the treatments. And then thinking about how do we utilize some of this in terms of value of care? Where I believe that the power of data really lies is in understanding how do we allocate resources towards different patient populations. To your point about patients who are more well off financially in more developed countries, there are significant disparities in terms of both education and the resultant effect on how patients experience that care. And what we know is that there are educational gaps around what toxicity means and how it affects patients longer term. And so what we're really seeing is the utilization of data that often comes from the cancer patient care journey to inform how we can actually improve the value of care. And in particular, are we doing a good job of making sure that patients uniformly understand their cancer treatments and how to manage those cancer treatments and the toxicity they might experience? How do we keep patients out of the hospital? How do we work with the amazing personnel that we have, social workers, nurses, physicians, to reinforce that education to help keep them out of the hospital for things that don't require or can be prevented? And so I think what we're seeing is that the velocity and the volume of data that's coming out of the cancer treatment experience is really shaping the ability of AI algorithms to risk stratify patients in a better way. And risk stratification can really occur not only in terms of the type of cancer, but as well as education level, so that we can actually appropriate the resources in a more definitive way that helps patients that need that additional education to better understand their disease and how to manage it. And so I think that's what's going to be a real driver of cancer care in the future in terms of value. And value, I see it in two ways, both bringing down the cost as well as improving outcomes. And so I think that's really where the power of technology lies, and in improving the value, improving the coordination of care, and more efficiently utilizing the vast resources we have in this country.
Thank you for that. And we're just about out of time, but Felice, I'd like to turn to you to close, to pick up on Anshu's points about education and communication. How can, from your perspective and also in the work that you're doing and going forward in the work at the World Bank, how can these issues be elevated, and also the importance of early detection, early treatment, and access be broader socialized, so that there is greater awareness of opportunity or greater awareness of the need to get in early? How are you seeing that in both your personal experience, but also in the work that you're doing?
Thank you, Allison, and again, thank you to Foreign Policy and distinguished group of colleagues and panelists here. I think of it in a couple of ways. One, I can't agree more with Anshu in terms of the need to be able to bridge gaps and divides early on. And so I think there's a couple of examples of that. We talked a little bit about the World Bank kind of making that an integral part of their strategy and their projects from the very beginning, and also thinking of the bank almost as a knowledge bank, not just as an economic development, multilateral development bank. So that's one thing. The other thing is that in the private sector, I'm seeing a lot more companies that are thinking global first. There's one company that I referenced in terms of taking defense-grade sensors for early detection of breast cancer, focused on the elasticity of tissue that doesn't necessarily have to be applied or administered by a doctor, or not even necessarily by a medical professional, a handheld device that's like a mouse. They're FDA Class 2 medical device, but they have already trials in Latin America and in the Middle East. So they're already thinking about it from that perspective. And then the last one I would say is capacity building. Also part of the President's cancer moonshot, and also something that he announced, and the First Lady at the U.S.-Africa Leaders Summit, is the Global Pediatric Brain Tumor Network. with a partnership between Bayer and Duke. So it's a public-private partnership focused on capacity building in Africa, as well as giving access to many of our systems here in the U.S. So I think, again, it's going to take a whole of government, but also a whole society approach for us to be able to truly end cancer as we know it. And if I can put in one last plug, if you haven't already engaged with the administration on the Cancer Moonshot, go to whitehouse.gov/cancer moonshot and how you can get involved.
Wonderful. Thank you. Thank you all for advancing the science, helping us to understand it more, for the work that you're doing day in and day out on this issue. We appreciate you being here, and thank you again.
Next, please welcome to the stage Chief Medical Officer and Executive Vice President of the American Society of Clinical Oncology, Dr. Julie Grallo, President and CEO of the National Minority Quality Forum, Dr. Gary Puckrin, and Vice President of Global Health Equity and Policy Partnerships at Bristol Myers Squibb, Manan Shah, for a conversation with FP's Vice President of Research, Dr. Maisha Alam.
Hi, everybody. Good morning. I am so honored to be here with such an illustrious panel of leaders who are working across academia, industry, civil society to really dig deeper on a few of the themes that we were hearing about in the previous conversation. And in particular, this discussion is on equitable access to care and how do we make sure that the resources, the innovation, the knowledge that is being channeled across the globe is done in a way that meets the needs of everyone. And so I'd love to start this discussion by actually going to you first, Manan, and asking you, from your perspective, what are the barriers to cancer care, both domestically and abroad, and how are different regions impacted in different ways? Can you help us understand what that disparity looks like?
Sure. First off, thank you for the invitation. It's great to be here. The latest numbers show that there's about 10 million deaths annually due to cancer, and 70% of those are in lower middle income countries. And that's projected to grow to about 16 million by 2040. So we know that this is an area of focus, and what's interesting is how it's approached. One of the things that we're focusing on at Bristol Myers Squibb is looking at the determinants of health and what are the causes, the underlying factors. So even before a patient is getting into the clinical care setting, what are the areas that can be changed, that can be focused? Dr. Young mentioned some of them, such as lifestyle and diet, changing that. I think what's encouraging to me that we've seen in recent conversations is a broader focus on what is access. Medicine obviously is part of it, but even beyond that, it's talking about issues such as the healthcare infrastructure that's required for proper cancer care, the education and training of healthcare professionals, regulatory pathways. And what we're finding is that when the discussion around these points broadens and we're able to bring more stakeholders to the table to have these conversations, you're starting to see a greater focus, which is really, really encouraging. We heard Dr. Young earlier mention the U.S. Cancer Moonshot, and that's fantastic. To broaden the lens internationally, in Europe, they have a different approach, and the Lancet Commission on Cancer talks about the European ground shot. And what's fantastic there is they say, yes, Americans are ambitious and bold and think highly, as they should, But here in Europe, let's look at the practical facts. What can we do about infrastructure? What can we do about implementation? What can we do about real world data? And it's a great approach that they're taking in Europe, which I think we can learn from here as well, and also in other parts of the country, of the globe.
Thank you for that. And it's really interesting to hear you talk about the different approaches regionally and the strengths and weaknesses of those. And there's one thing in particular that you said that I thought was really important, which is when we say access, what are we actually talking about and for whom? And so, Gary, I'd love to turn to you next and bring you into the conversation. And in particular, when we think about the course of a patient's journey and their ability to access care, how can we ensure equitable access through the whole spectrum of care? So whether that's diagnostics, detection, trials, and treatment. Can you tell us a little bit about that?
Well, first of all, thank you for the invitation to participate in this conversation. So the National Minority Quality Forum, we have been working with the White House on the Cancer Moonshot. And in part of that work, we've actually been in communities around the country like Flint, Michigan, and Kashmir Gardens in Houston, Texas, where they believe they're experiencing cancer clusters. And we have a couple of takeaways from that experience. First of all, we have communities in the United States that are being exposed to carcinogens, and it's raising their risk for cancer, and that was done by public policy. And what we also see when we go into those communities is that public policy is denying them access to quality care. And so they have this twin evil of public policy heightening their risk and public policy not giving them the care. And when you dig a little bit deeper to try to understand, at least on the medical side, why is that happening, is because there's this underlying theory in American healthcare that we can't provide. There's an unlimited demand for healthcare and a limited supply, so we have to ration. And we are rationing care in this country, and necessarily for poor and minority populations, they get the short end of the stick. And it turns up in geographies all over the country. So part of the Cancer Moonshot, as we see it, is that we have to go into those communities and we have to repair public policy. This is really a public policy conversation because the technology is fabulous, incredible. And I love NIH and I love ARPA-H and I love all of that new technology. But if you can't bring it down to the community, it doesn't make any difference, right? And so the work that we're involved in is going to ground, is to get into those communities and demonstrate probably the most important lesson is that we can actually provide quality care and pay for it simultaneously. That's really the big lesson that we have to be able to show. Because for those who make the argument that we can't provide care to everyone because there's this unlimited demand, there's absolutely no science. It's absolutely made up, right? It got made up in the 1970s and 80s, and we need to repair that. And the best way to repair it is to go into those communities, provide them quality care, do the financial modeling associated with it, and come out the other side with scalable models that say we can pay for quality care for every American. And I think that's how we're going to reach the goals that the president set out for the Cancer Moonshot.
Thank you for that, Gary. And I appreciate you really kind of bringing us to the ground level, as you put it. And you touched on technology, and it's something I want us to come back to later in this conversation. But Julie, I'd love to actually pose the same question to you first. And from your perspective, hear a little bit about how you believe we can ensure equitable access across the spectrum of care, whether we're talking about diagnostics, detection, clinical trials, and treatment. How do you come to this?
Well, I was a breast medical oncologist and a professor of global health for 30 years before taking my role at the American Society of Clinical Oncology as the chief medical officer. So at our mission at ASCO is conquering cancer through research, education, and the highest quality, equitable care. So I think defining value and high quality care is part of how we're going to afford it. Because we are doing a lot of things in our country that aren't of high value. If we stopped it tomorrow, it wouldn't harm anyone. I think our European colleagues kind of backlash, if you will, and saying they're going to counter the moonshot with the ground shot is very applicable in the US too. We could save tens of thousands, millions globally of lives tomorrow if everybody could get access to the same early detection, diagnosis, treatment, supportive care, et cetera. So we need something in between a ground shot and a moon shot. I've been struggling with the catchy phrase. I'm kind of thinking of a jump shot where you're going up in the air a bit, but you're not leaving the ground too much, so I'm working on that. So, there are lots of barriers. I'll give you an example. We did, to clinical trials, we did a pilot with the ACCC, the Association of Community Cancer Centers. And it was looking at enhancing enrollment to clinical trials of underserved populations. We focused on Black and Hispanic Latinx as a start. There were two pods. One was a site self-assessment. So 70 sites signed up to do a site self-assessment, not just understanding who's enrolling in a trial. We know those numbers. We know who makes it to the trial. But going backwards and trying to understand why our minority populations don't enroll in trials. Who did you screen? And how many of them did you actually offer a trial to? And if you didn't offer it, why didn't you? Was it because of ridiculous eligibility criteria that don't matter? Was it because of implicit bias? You thought it might be too hard for them to come in. So understanding where it falls apart along the way. The second part of it was an implicit bias training. And it was really called Just Ask, because we've done research. I was part of the SWOG, National Clinical Trials Network, as an executive officer for years. If you offer Black, Hispanic, Latinx, older patients, those who don't enroll in trials, if you invite them to enroll in a trial, they generally enroll at the same rate as the rest of the population. So it's really about getting to the ask. So that's one way. We've got to understand why care isn't equitable, why patients aren't accruing to clinical trials. A lot of it is they're never even asked in the first place.
That's so important, and that's so interesting to think about, like the assumptions that are made. As you were saying, there's the issue of implicit bias, but also how difficult or easy are you making it? And is there an enabling environment and conducive conditions to allow for that? And one of the things that in the previous segment there was quite a lot of conversation about was with respect to the role of technology. And Gary, you brought this up as well. And of course, there's an enormous amount of excitement about the transformative potential of emerging technologies and AI in particular. And so I'd love to ask all of you about the connection between the role of technology and equity. And in particular, what role do technological advancements like AI play in achieving or complicating the ability to reach equity? Manon, I'd love to start with you first, and then maybe we can work down the line.
Sure. I think that as captured well, there's a promise and a peril that comes with technology like AI. I think there's a recognition of all the potential that is out there for it to advance healthcare. At BMS, we've implemented an internal ChatGPT function to help us streamline some processes, look at clinical data, and some other fantastic things that we're just starting to explore. But I think what we've also realized is, what is the data that's being put in to improve the algorithms? What is that taking place? And in multiple cases, we've seen examples where, for example, apps that look at skin to detect skin diseases, they aren't testing as accurately on skin of color because that information hasn't been fed to them to improve those processes. So we can get very excited about the promise and everything that can be unlocked, what can be achieved with things like AI, but I think just as importantly, we have to focus on, as Julie said, are we asking the right questions? Is this setup done in an equitable manner? And if not, then that's something that has to be addressed, that has to be called out and not, pushed to the side in this excitement of this new and exciting potential technology.
So one of the technologies that we are paying a lot of attention to that we think can be really transformative in these underserved communities, we call them medically underserved cancer care communities, because these are communities in which they quite literally are not getting access to best modern therapy. And as I said before, they're also being exposed to carcinogens. And what we're looking at is multi-cancer early detection screenings. These are new devices that have the capability to screen as much as 50 cancers at one time for cancers like pancreatic cancer where we don't have any screening tools. They also can diagnose the patient at stage 1 and 2, or at least give a signal, let's be clear about that, give a signal about whether there's a stage 1 or 2 cancer. We think that those are great surveillance tools for populations that we are engaged with, meaning they would give us the ability to screen thousands of patients at one time in Flint, Michigan, and Houston, in New Orleans, et cetera, et cetera. And so we are putting together a 50,000 patient study using those MSIDs to screen populations. And then when we get them diagnosed, we also want to transition them into best modern therapy. Here's the point. The point is that cancer care now should be really being done at stage 1 and 2. What we see in the communities that we're working with, they're getting diagnosed with metastatic cancer. Their survival rates are poor. And even more importantly, in some of these communities, they're coming down with these rare cancers. They're incredibly aggressive, and we need to pay a lot of attention to them. We're also going to collect a lot of genomic data. We're going to be sampling these populations genomically and hopefully come up with a huge database that will allow us to better understand the epigenetics and proteomics and everything else that's going on with these populations. African Americans have the highest level incidence of cancer of any population in the United States, and we don't know why. And so part of what we're working on is to try to put together the data so that we can begin to answer those questions. The science is here. Our problem really is that we've got public policy that's lagging. I mean, you live in Washington, you hear the debates. It's silly debates, right? When we have capacity to really transform cancer care. What we would argue is we're about to write the last chapter on the war on cancer. We have that capacity right now to start writing that chapter. And that's what we want to help do. We want to help write that last chapter right now with a sense of urgency, because in the communities that we're talking about, people are dying when they don't have to, and we need to take on the responsibility. We would argue it's public policy, which means that we're all responsible for this. We are doing it. And so we are pushing everyone to join with us, to go into those communities, and let's help those who right now we've exposed to unusual risk.
Our board has decided that the theme of our annual strategic planning retreat this year, which will be in March, is going to be AI and technology in oncology. So in a few months, I'll have a much more refined answer to your question. That being said, I really think we already have telepathology, teleradiology, telemedicine, which we didn't really use before the COVID-19 pandemic in the US, in large part because of the regulations around it. You know, you had to live in a rural area, you had to go to a clinic, and the patient had to go to a clinic to talk to a doctor through telemedicine, et cetera. And then there are all the cross-state licensing boundaries. But the idea of using technology to bring the treatment to the patient is really a huge advancement. And I think that there are also some exciting advances. We talked a little bit in, I think it was the last panel, about the computer algorithms for reading pathology, for reading radiology. And, you know, there's been a lot of hype about how computers could maybe better detect on mammogram very early cancers. Well, you know what? We have a big problem with overdiagnosis on mammography already, where we pick up precancers or little tiny quiet cancers that never would cause a problem in a lifetime. So I'm not as excited about technology being able to, on a screening mammogram, for example, better detect cancer. I'm really excited about recent data that shows that computer algorithms can read a mammogram and pick out 75 to 80% of mammograms that are 100% normal. You do not need to worry about them if you don't have radiologists in your country, you know, you don't even need to focus on those. You push those off in a pile, and you use your limited supply of radiologists to really look at, or you send it over to teleradiology and get expertise someplace else. I'm actually more excited about this helping with the capacity to be able to read all the screens that are happening and weed out all those that are normal, so that when you go into a country that doesn't already do cancer screening routinely, and you say, now we're going to have a bunch of mammograms in healthy women, you don't need to really build up your imagers, your mammographers, to that same degree. So I think, you know, we also don't need high-tech technology. There was a paper published just in the last week or so of a study out of Kaiser in Washington State looking at, for HPV swabs for cervical cancer, instead of the healthcare provider doing it, giving patients who had missed their visits, randomizing to mailing a self-swab. And then they mail it back in. And mailing the self-swab versus just sending reminders and saying, come in for your exam, increased the screening. I mean, we have to think about low-tech technology and how it's going to help get in those who wouldn't come in a traditional way either. So there's lots of opportunity, really excited about it, but we can't just be thinking about super expensive high-tech kind of stuff. Low-tech works too.
Well, I love that last example too, because it's a reminder that by sometimes overcomplicating things, you may be missing opportunities and missing the ability to leverage what's already there. And I wanted to pick up on a couple of things that Julie, you said, and Gary, you said earlier too. Julie, you were talking about telemedicine and that being an important shift, if you will, during the pandemic, and how this period of enormous crisis, global crisis, it required us to think differently and to do things maybe differently than we have done in the past. And Gary, earlier you were talking about the importance of making sure that public policy doesn't get in the way, and in particular in the communities where you are focused, it's not just that they are medically underserved, but that they're also exposed to disproportionate risks. And so taking all of that together, I wanted to ask you, all three of you again, what are some of the most important lessons learned at this moment that you think people need to understand if they really want to close the equity gap? From your vantage points and the incredible work that you've done over the course of your careers, what are the things that you think are the most important lessons that often are left unheard or get missed? Julie, maybe we'll start with you on this side and then work our way down to Manan.
Well, my first thought is that we need to understand the importance of partnering with patients and patient advocates in overcoming some of the barriers. There is a lot of mistrust out there of the medical profession. Going back to Tuskegee, et cetera, so partnering with patients and patient advocates to try to just have dialogue around that. So an example is I practiced in Seattle for 30 years, still live there, partnered with a patient of mine who formed an African American breast cancer support group, and every year during Black History Month, to tie into World Cancer Day, we would have some community event, and we would have music, have prayer, and a couple of years we showed movies. One was The Immortal Life of Henrietta Lacks, and then we had a panel to discuss and really have dialogue with the community. What happened? What are we doing to try to correct that? And just say it was wrong, and we need to get, work on preventing this from happening in the future. We showed Ms. Evers' boys. Ms. Evers was a nurse during the Tuskegee experiments, and she, had her boys, and she stuck with it even though she knew this was a horrible injustice, because she was the main person providing health care to them. And so dialogue around that, and yes, it was wrong. It was awful. We understand your mistrust. How can we regain it? And in Africa, for example, we went in, the Fred Hutch Cancer Center has a relationship with the Uganda Cancer Institute, and I was part of their HEMONC training program. And in the beginning, going back 12, 15 years ago, we did focus groups around why were women presenting late when they knew they had a lump in their breast for a long time. They knew it. They knew it. They knew it was probably cancer. Why didn't they show up until it actually hurt or it was coming through their chest wall? And it was because when we did these focus groups, we couldn't find anyone who knew a cancer patient who had come to the cancer center and been cured and went back to the community. They didn't know a single cancer survivor. So we partnered with the Ugandan cancer survivors to do events and say, I survived, my husband didn't leave me. That's another problem in many countries, or he didn't take a second wife. I survived, and you can too. And so the importance of partnering with the patients and the education to overcome some of the mistrust and misinformation. There's too much misinformation about there. But to show that, one, you can survive a cancer, but two, to actually they can provide support as well.
Yeah, amazing.
Probably the deepest thing that I've come to understand is around public policy and health. It really, Edwin Schrödinger, a physicist in 1943, wrote a book called What is Life? And the essence of what he was saying is that life is emergent from a set of physical laws. And basically, if you follow the logic of that, public policy has to follow the science. It doesn't have a choice. There's no option. Every human being on the planet, right, has to follow those physical laws in order to be healthy. Putin, Trump, Biden, you name them. And what's happening now is that our public policy doesn't follow the physical laws. It doesn't follow the science. They make it up. And they make it up because they think they have to ration care, and they necessarily pick winners and losers when they do it, right? And even for those who get the benefit, also lose because it's not following the science. There is no option. There is no plan B. And so when we look at public policy, what we talk about, is it mitigating patient risk or is it elevating patient risk, right? And that's the measure. Is it elevating? And we have a lot of public policy that elevates risk. And you see it in the communities that we go into. That's probably the most important lesson I can say to you that we've learned, that public policy has to follow the science like everybody, like the doctors do, like FDA does. There's no sideway here. And that's the challenge that we have, and that's where the refocus on public policy has to be. That congressman that was sitting here this morning, you need to tell him that he's got no option either, that he and his colleagues also have to follow the science.
I think there's two things that I would like to highlight. Number one, you have to bring everyone to the table. There has to be a seat for everyone involved here, because the reality is addressing these issues of equity is too big for any one entity, any one government, anyone to just do by themselves. And the benefit of bringing different partners together is that you're going to be able to learn things and get access to parts of the world or different community that you yourself would not be able to do. So for example, we've been proud to support BioVentures Global Fund in Africa because they have the expertise on the ground, and they've been able to train over 1,600 cancer pharmacists, oncology pharmacists in African countries. That's something that we ourselves would not have had the reach to do, but working with them because they have the local infrastructure, the know-how, that's a partnership that we've been able to leverage. To Gary's point, one of the things that we've learned is the importance of policy at the city level. So City Cancer Challenge is an organization that works recognizing the city infrastructure, city policy, city level dynamics can be incredibly influential for cancer care. So we're sponsoring their work with the World Health Organization as Global Breast Cancer Initiative to reduce deaths related to breast cancer by 10% in the coming years. Those are partnerships that are able to take us further and do more than us thinking that we can do this ourselves. The second thing I'll say, and touching back to comments by Julie and Gary, you have to listen to the patients. You have to listen to the patients, to the caregivers, the ones that are living this experience day in and day out. Because the reality is we can sit here and talk about these broad terms and social determinants of health, but a patient is not thinking in that concept. We were at the American Society of Hematology this past weekend in San Diego. My colleague Andrea, you're here, so keep me honest. We had the lead of a patient group stand up and tell us that they did a survey about the surveys that they're sending out to their patients of what works, what doesn't work. And the number one feedback they got was that patients hate the term financial toxicity. They don't want to hear it. They don't want to be told that their situation is toxic. And if you take a step back, yeah, who wants to be told they're toxic or in a toxic situation? So having these encounters, these engagements, sitting down and really understanding from the perspective of the patient, the caregiver, the community, is going to be so important to be able to connect with them, and rather than sitting back and wondering, why is this not happening? Why isn't this working? We got the best experts, you know, sitting here thinking these ideas up. Well, if you're not talking to the patients themselves, it may not work. And then you're going to scratch your heads wondering why.
Thank you for that. I mean, there's just so much wisdom in what each of you have said. And as I'm listening to you and trying to kind of distill, you know, the maybe just to put a finer point on it, what you're saying about understand what the patient wants, what they don't want, and what they're scared of, right? And also follow the science. Ultimately, that has to be the North Star. And to your point, Julie, meet people where they are, right? Be honest with them and understand where they're coming from if you want them to be able to feel like they're being cared for. Well, thank you to all of you for the incredible work that you are doing in your respective roles and over the course of your journeys. I think there's a lot here that we can continue to think about and continue to try to work on. And I wish you the very best in everything that you are doing. Thank you so much.
Thank you.
Next, please welcome to the stage the World Bank's Global Director of Health, Nutrition, and Population and Director of the Global Financing Facility, Dr. Juan Pablo Uribe, for a conversation on closing the global funding gap for cancer care.
Juan Pablo, welcome. Thank you so much for being here. It's a real privilege for us to have this opportunity to engage with you.
Thanks to you, Mayesha, and to Foreign Policy, and also to Burjeel Holdings for this effort, by the way. And thanks to everybody who's here for attending and dedicating some time on a busy week to such an important topic.
Indeed, and I don't know if you were listening earlier, Juan Pablo, but the incredibly important role that the World Bank plays with respect to cancer treatment, cancer care, came up actually multiple times in previous segments. And so I'm especially keen to have this conversation and hear directly from you a little bit about both what the bank is doing, how you're thinking about these issues, and how you're working with partners. And so to get us started, I'd first love to ask you, how can the global funding gap for developing and delivering cancer cures be closed? From your work at the World Bank, are there any innovative mechanisms for closing the funding gap that you think are promising and that you want everyone to understand?
So I'm sorry, because I do not come here with a solution to such a big challenge. I think the most useful response has to be a realistic and practical one. There's a funding gap for cancer, but there's also a funding gap for health overall. And it's a huge one. We were talking about it. This is a moment where new needs are coming into the financing agenda in the low and middle income countries. Just think about pandemic prevention, preparedness, and response coming out of COVID. That need to be better there. Just think about last week and this huge intersection between climate change and health and what it implies in financing terms. Just look at the burden of NCDs, not only cancer, look at mental health. And wherever we go, any topic, any disease, infectious or non-infectious, neglected or not neglected, has a huge funding gap. We've been following all the low and middle income countries and their spending patterns, Mayesha. And it's a work that we call the double check, double recovery, following the COVID pandemic experience and all its effects on the economies. And we're seeing almost 50 countries around the world are facing, during this year and the following 2 or 3 years, per capita public expenditures below what they had in 2019. So think about it. A shrinkage in budgets brought by inflation and the devaluation of a lot of the local currencies. So it's a very difficult situation. And just to make it more difficult quickly, with WHO every other year, we do a global monitoring report on what's happening in the progress towards universal health coverage. Very basic, two variables, 2 indicators. The first one, access, again in low and middle income countries, to essential health services. Of course, screening for a breast cancer has to be essential, just to give an example. And what we're seeing is that we are backtracking there. And the second indicator, financial protection for households when seeking care. And imagine cancer care. And what we're seeing is that we're losing financial protection for households. And we're forcing, by trying to resolve health issues, we're forcing more families into poverty than before. So this is the reality. Now, I'll stop here. I do believe there are things that we can do, but I'll turn it back to you. But I did want to start with a little bit of realism. This is what our countries are facing, by the way. And this is where the funding gap for cancer is. And that's where we need to act.
Well, and thank you for that reality check. I think it's a really important one, and some of the data points that you were sharing with respect to, in particular, the fact that per capita expenditure has gone down since the pandemic. And when we look at where things were even a few years ago, and also the point that you made, and you use breast cancer screening as an example, but how do we take a holistic approach to health? Because it's not that, you know, cancer is somehow isolated from, as you said, other NCDs, but also overall health care, right? And a person's health over the course of their life. And, you know, the question that I wanted to go to next was, okay, so we've had the reality check. Clearly there's a funding shortage. Clearly there are competing demands when we think about even health expenditure, let alone health and other issues. So what can be done, right? And in particular, from your perspective at the World Bank, what do you see as the role of the private sector in mobilizing capital? And what role do public-private partnerships play?
It's an excellent question. So now I'm turning into my optimistic Juan Paulo here. I think governments have a lot of instruments in their hands to try to reduce this gap and progress. There's not one single solution. All of them will take a long time, by the way, so consistency here is very important. But they have to be, in a way, embraced by a health system strengthening approach. And that's what the World Bank does in health. What we do is we come to countries with all our support, always thinking on how any particular intervention or need, in a way, is embraced or fits into a bigger, more holistic health system strengthening, longer-term result. First thing, health has to be a priority and investments in health have to increase. And that needs to be reflected in the national budgets. We still have countries with 1% or 2% of GDP going to the health sector. We still have countries with single-digit public expenditures ratios in health. So as somebody told me in my past life, in the public administration, love is expressed in the budget. We need to see love for health systems and for the health sector expressed in bigger efforts, even in the lowest income countries, relative to their capacity. Second, efficiencies. There's a lot of inefficiencies, and this will be a continuous battle, Mayesha, in terms of stopping leakages, corruption, misallocations, strengthening public systems, strengthening financial flows, being able to do expenditure tracking and know where the money is reaching the services, etc. Third, and for me in cancer, this is particularly important. I think we have walked away a little bit from the risk pooling mechanisms. Call them as you wish, but in conditions like cancer, especially in the higher cost of cancer, risk pooling is fundamental. So it's nice to see a country like Morocco advancing with a holistic health insurance reform for the country with strong private sector participation, where cancer is included in the health benefit package, and people will have, again, through a risk pooling mechanism, the capacity to access cancer. Effectiveness, quickly, think about all what we can do in better balancing within health systems the preventive and screening aspects with the curative needs. Think about HPV. Right now, the most cost-effective vaccine in the world, the one with the lowest coverage rate, has all to do with the possibility of hundreds of thousands of women not having a cancer, again, with a very small investment. Serbia, to give another example, with the support of the bank, is doing a comprehensive health system strengthening work that starts in primary health care, starts on prevention screening, but goes all the way to national referral centers for the higher complexity cancer treatments. Lastly, private sector participation. Côte d'Ivoire, in a project between the IFC and the HMP side of the bank, the private and the public sectors of the World Bank, has brought the private sector to have a responsibility throughout all of its territory in the imaging and screening aspects of health, which are paramount in a lot of the cancers. So beautiful example of private sector participation. Lastly, the private sector brings with competition, quality and innovation. So proper regulatory environments, Mayesha, for the private sector are fundamental. I can talk a lot about LAC. I can talk a lot about Colombia. The biggest chunk of cancer treatments in Colombia are private sector provided and publicly funded through a mandatory national health insurance.
Well, thank you for that. There's so much there that you said, and as I was listening to you, I thought he's really, not just taking us in an uplifting direction, but also I loved the examples that you shared of what's working and what's promising. And as I was listening to you, you shared examples from Morocco, from Colombia, from Serbia, and from Côte d'Ivoire, right? So 3 Global South countries, 4 LMICs. And I think it's a really important point to underscore that a lot of the innovation and a lot of the initiatives that are taking place in countries that we may not necessarily look to for that kind of leadership. And earlier, one of the panelists on another segment described the World Bank not just as a funding bank, but also a knowledge and expertise bank. And I couldn't agree more. And so one of the things I'd like to ask you and to help close our conversation is what more needs to be done from a technical standpoint, from a financial standpoint, from a partnership standpoint, from a convening standpoint, to ensure equitable and universal access to cancer treatments globally?
Wow. First, I would love this conversation not to end, really. You're a great moderator, and look at this audience. But on that, we need to maintain the visibility of this topic and its presence in the agenda. Again, with so many competing needs, it's so easy to walk away from it and come back in 2 or 3 years and find the same results. So visibility and insistence, again, I think it's paramount. We also need to help leaders at the government side to have the proper technical inputs, the correct data, to implement the proper policies, again, with a health system strengthening aspect. So technical assistance is going to be extremely important. By the way, putting cancer into a health benefit package in a mandatory insurance is not an easy task, maintaining the sustainability of that financially. So there's a lot of inputs that we can bring into the discussion. And again, maybe understanding that this will not have an easy, immediate solution, that there's no shortcuts here. This takes place in our countries. It will take place tomorrow and next week and the following year, and we need to insist in maintaining that very close company and support to the local leadership. There's no global solution for this. There can be very strong global advocacy, a strong global mobilization, great leaders like the ones in here, but the solutions to these problems will only take place at the national level in our low and middle income countries, and for most in the subnational and local levels. I did hear the last panel talking about patients' expectations, and I want to close maybe my comments from that. We always look top down. It's going to be very important to always connect bottom up, starting with that woman who has screened herself for a breast cancer, has found something, and she has to be taking her decisions within a system that respects her and supports her.
Thank you for that. Thank you for the reminder that it has to be bottom up, top down, but also, as you put it, ultimately we're talking about individuals and their well-being and their families and their communities. Juan Pablo, we're almost out of time, but I wanted to end this discussion with one last question to you, which is, when there has been coming out of the pandemic, and we were hearing about this a little bit in the previous segment as well, challenges with inflation, decrease in per capita spending, public spending on healthcare. How do you keep cancer visible? You said that earlier. We cannot lose sight of it. How do we keep it on the agenda and keep it visible?
Wow. I think there are incredible leaders at the community level who will not let us forget about cancer. I'm thinking about my country, and I know an incredible number of NGOs that will never let go on their purpose of having better solutions for cancer, because they've made it their own mission, their own purpose, and it's a life motif, by the way. I'm sure it happens everywhere. At the same time, we will continue doing the thorough and honest analysis of health systems and of burden of disease, and we all know that cancer will become more and more prominent as well. So I think we also have our homework there, Mayesha, in again bringing those facts to the table so that the policies can, as much as they can, be evidence-based, and in that space, cancer will always be there. And lastly, I think we need to mobilize resources like you've done today, by the way, and again, congratulations. You bring together the academics and the private sector and the multilaterals and maybe government authorities as well and Congress people. I think that type of mobilization needs to continue. I think that's the way.
Well, thank you, Juan Pablo. Thank you for your insights, for your leadership, and for your call to action. It's wonderful to have you here.
Thanks to you all.
And now, please welcome to the stage the founder and chairman of Burjeel Holdings, Dr. Shamsheer BLL.
Hi, how are you?
Dr. Shamsheer, thank you so much for your partnership and enabling us to convene this group of esteemed experts, Congress people, scientists, to really address what is such an urgent issue. And I echo Juan Pablo Uribe's comments. I don't want this conversation to end either. I've learned so much throughout the course of the last few hours. And so much was raised about the importance of putting a human face on cancer and really addressing needs at a community level. The community shot and the moonshot, and as Julie well put it, the jump shot. Needing to make sure that we're reaching those in need where they're at. And also, what was just encapsulated in the last conversation is we're in a challenging global environment. There's high inflation, there's debt, there's constrained budgets, and there is a massive funding gap to address cancer. And so, this is your passion, your life's work, and I'm wondering, as you're listening to this conversation and thinking through how can we achieve these goals, especially in places like Yemen that don't have the health infrastructure, that don't have the resources to have necessarily the advanced technology? What needs to be done now, and what needs to be understood by this audience and others about what needs to be prioritized to actually have the impact and achieve the goals that we're all looking for?
Thank you very much. And I think I want to thank FP for organizing this at such a short notice. And it really struck me by hearing out what has been discussed. And that's what we are looking for, right? From the senator to the World Bank. The interesting fact of life is post-COVID, we have become tougher, more resilient, more health conscious. I think it's never been a better time to address cancer as an issue, and the hope prevails. I think that's what the best part of whatever the discussions has happened today. But I think for us, we come from the part of the world which has always been looking at a different aspect of care than what you would look from the US. And I always told that if you ask me, one problem in healthcare is that we don't look at scale in healthcare. Because if you see the big US providers, they're all pretty much inside the US, and very few have gone out. And there's always a secret recipe in place. So what we want is democratize things like cancer, because everyone wants to live happily across the world. And the same as a cancer patient in here versus cancer in Yemen or any part of the world, they want to live. And the financial toxicity has been a bigger challenge, mental health challenges associated. We have pediatric cases increasing. We've been just, we announced, UAE announced the intention to treat 1,000 pediatric cancer cases from Gaza. So, we never have enough. We need more ideas, more discussions, more of moonshots, jump shot, whatever you can call it. We want NASA to involve, we want Hollywood to involve, we want the Bollywood to involve. So I think we want more collaborative approach. We want not just private players, we want the public, politics to be kept aside, boundaries to disappear. We want a multi-stakeholder approach. And I think inclusion is the most important challenge. We need the health equity gaps to reduce. We need a lot more data. We need more technology. We need more people to be trained. So I can go on and on, but I think this is the right intersection of people like us meeting in a place like Washington to discuss and see how we can be of some help to people around the world.
Thank you for that. And it is an incredible opportunity to bring together such a diverse group of experts and those who are dedicated to addressing this issue in various ways. And as was mentioned earlier as well, we are all part of this, and we all have a responsibility and an opportunity to play a unique role. And, this is the 10th anniversary of the Oncology Conference. And I'm wondering if you can reflect for a few minutes about what you've seen that has worked well and had impact over the last 10 years. And when you think about the next 10 years, what do you foresee happening, and what needs to happen right now to enable that to be realized?
I think one good thing that life has taught us is post-COVID, we can fight things with much more hope. Where we thought life was coming to an end, we found a solution, we fought through, we are much more active than what we used to be. So for me, the hope part is better than ever, and I think I strongly believe that there definitely would be a cure for cancer, and I'm sure this is going to happen in the next 10 years if we continue the same stream of work with AI coming in, with drug design, and if the CDCs of the world, if the FDAs of the world pull up their sleeves and come really outside of their offices to see what patients are going through across the world. I think we need a faster, accelerated approach with all the space, medicine research that is happening, and we need to go into an accelerated mode rather than a over-cautious, worryful thing, because we all have someone or the other having very close brush with cancer, and it could be any one of us. And I think this is the best time to really move from think tanks to do tanks. And I think we need more action. We need to call for action. We need the World Banks and all the banks, the central banks, the large corporations, the pharmaceutical companies, everyone to have a common goal. And I think that is what is in the best interest. And I come from private sector, so we have ability for, I always say speed is our weapon and speed is our enemy. Because we need to move fast, we need to act fast, we need to have much more closer collaborations, and I think I'm very optimistic that there would be some kind of a disruptive thing that would happen in cancer care.
And I think it will happen with your leadership, the expertise in this room and around the world, and utilizing the data to inform those decisions to ensure that with the resources that we have, we're having the greatest near-term impact as possible.
Sure.
But I just want to thank you for being here, for your partnership, and helping us to assemble all of you today. This is an important conversation that definitely cannot stay in this room. We need to carry this forward and continue to have impact and the action that you describe.
We already discussed our next meeting in Davos, so we hope to continue this discussion.
Yes,
thank you.
We hope to see you all there.
Thank you so much.
Thank you so much.
Thank you.
Brings us to a close. Thank you everyone for being here again. Thank you to Burjeel Holdings, and please stay, eat, drink, network with each other. We're really excited to tap into all of your expertise. So thank you again on behalf of Foreign Policy. Have a great day.